Yeah, it's February. 2 R's in February. This is the Persiflager's Puscast, a review of the infectious disease literature with some commentary for the first 2 weeks of February 2011. You can always skip this introduction, but there are things I gotta say because it is CME accredited. When you're done, you can take a quiz and get a half an hour of free CME thanks to Legacy Health. But because it is CME accredited, I have to mention my conflicts of interest. Just the wonderful website, moremark.squarespace.com, where you can find the Infectious Disease Compendium, a Persiflager's Guide, as well as the Pus Whisperer, a year in the life of an infectious disease doctor, and all the other things that make up the growing multimedia empire of Mark Crislip, because the world needs more Mark Crislip. But you're sick of this, so we're going to move on to the literature. The Cochrane Reviews published a recent analysis of the studies for zinc with cold. Those of you that listen to my Quackcasts or read science-based medicine know that I'm not that big a fan of the Cochrane Reviews, in that it appears that the basic theory behind all meta-analysis is if you take several piles of cow manure and put it into one big pile, you get gold. What you get is a big pile of cow manure. Anyway, they looked at all the articles that have been published about the efficacy of zinc against colds and found that it was of modest efficacy and had significant side effects. They found that when compared to placebo, people who got zinc were less likely to be ill at 7 days compared to people who got placebo, he said, being redundant. 37% of people being sick in the zinc group overall versus 56% in the placebo group, which isn't bad to shorten the length of your cold symptoms. So it has modest efficacy. Unfortunately, side effects were not uncommon, and we all know that zinc lozenges have been associated with loss of smell, which may not be too bad if you have a bunch of young kids at home. However, when you look at the modest effects and the fact that they note that the quality of the studies was only moderate, I would bet that as the quality of the studies of zinc and cold go up, its efficacy will go down. But I'm just a pessimist that way. I have talked about the emerging epidemiology of hepatitis E in the West. It's due to genotype 3. It's probably spread by consumption of pork products. It causes an acute hepatitis in most people and can cause a chronic hepatitis leading to cirrhosis in the immunocompetent. And in this review, it may be associated with some neurologic problems. This was an analysis of 7 patients who had hepatitis E, which is not great, but they found one encephalitis and a hodgepodge of peripheral neuropathies, including Guillain-Barré, like the French accent there, polyradiculoneuropathies, and demyelinating polyradiculoneuropathies. So it would appear that hepatitis E may be associated with some neurologic symptoms, predominantly peripheral neuropathies. However, association is not causation. And so if this is indeed causal, it needs to be worked out. There is a move afoot to make sure that employees are vaccinated against influenza, that it be a condition of employment. There are people who do not agree with that and think that it is a waste of time and money and a violation of their personal freedoms. The United Kingdom looked at the nosocomially acquired influenza during the 2009 pandemic of H1N1. They looked at 1,520 patients at 75 different hospitals. They found 30 patients who met the criteria for nosocomial-associated influenza. Most of these patients, not unsurprisingly, had significant underlying medical problems, and they did real bad. How bad, you ask? 53% escalated care or required mechanical ventilation, 27% of them died. So that's the risk you have. Now, it wasn't common. There were only 30 patients who had nosocomial pneumonia. But really, do you think the patient should die because you're such a weasel that you can't get the influenza vaccine? I ain't got no sympathy for anybody who works in an acute care setting and doesn't want to get the flu vaccine. You want to kill patients? Why don't you go out in front of the hospital and run over them with your car, asshole? But don't give them influenza. Vitamin D is probably more important as an immune modulator than it is building strong bones, which I believe is milk or Wonder Bread or something like that. Of course, I'm biased. I think everything concerning infectious diseases is more important than other aspects of medicine. This study looked at vitamin D levels in HIV-infected adults and found that just like U.S. adults in general, vitamin D deficiency was highly prevalent. The interesting thing is that there are things that were associated with low vitamin D specific to HIV. One was renal insufficiency, and the other was the use of ritonavir and efavirenz-containing regimens, which alter vitamin D deficiency. I'm here in the cold, dreary, rainy, cloudy, sunless Pacific Northwest, still the best place to live regardless. But they suggest as not only should Americans in general be screened for vitamin D deficiency, but HIV patients as well. Since having insufficiency of vitamin D does increase your risk for a variety of infections, primarily viral and mycobacterial. However, I want to emphasize all you need is to have a sufficiency of vitamin D. You just need to get your levels up to normal, either by supplementation or basking in the glorious rays of the sunshine. Extra vitamin D is the realm of the alternative wackaloons who think it is a panacea for every infection up to and including influenza. I like the term wackaloon. I think it's Australian. It's a good term. If you do a test on a bunch of people, you're likely to find anomalies, but sometimes you find them at rates greater than you would expect. In this study in CID, they looked at echocardiograms in HIV patients, and they found a lot of anomalies in these patients that were unexpected. They found systolic function anomalies in about 20%. They found diastolic function anomalies in about 25%. They found pulmonary hypertension of one form or another in about 55%. And then a smattering of increased left ventricular mass and left atrial enlargement, which they found in about 40%. These were including borderline, mild, moderate, and severe in all cases. But nonetheless, it was not an insignificant number of echocardiographic anomalies in a population of what were considered generally healthy HIV patients, most of whom were on heart therapy. And most of the patients who had anomalies also had the typical, sometimes treatable risk factors for having cardiac anomalies on echocardiogram, hypertension, etc. Hospitals are just too special to allow anybody to be admitted. Just because you have a little pneumonia doesn't mean you should be in the hospital. But there are guidelines to determine who should and should not be admitted to the hospital. And one of the things that's associated with increased mortality in this study I'm about to talk about was having a low O2 sat, the alleged fifth vital sign. There's a lot of fifth vital signs, just like there's a lot of fifth Beatles. But this study looked at 2,900 patients with pneumonia and looked at outcomes based upon oxygen saturations. And they found that when patients had oxygen saturations less than 90%, their 30-day mortality rate was much higher, 6% versus 1%, if the O2 sat was greater than 90%. Because of this, they suggest that what we should do is probably admit anybody whose O2 sat is under 92%. They estimate that this would entail one additional hospitalization for every 14 patients discharged. Though whether that would improve the mortality or not, I don't know. Maybe you're just going to admit them so they'll die in the hospital. And then that will just screw up your reported mortality rates. You can't win, can you? I rant frequently on rounds about the evils of non-steroidal anti-inflammatories. Generally speaking, being inflamed is good, and that blunting the inflammatory response may have downsides. There's always been a suggestion, for example, that the use of NSAIDs may be what predisposes people to go on to get group A strep necrotizing fasciitis. This was an article done by the French and looked at what happened when patients got NSAIDs when they had pneumonia. They found that patients who had NSAIDs were more likely to be bacteremic, 69% versus 27%, and more likely to get empyemas and lung cavitations, 37.5% versus 7%. NSAIDs probably tip things in favor of the organism by blunting the inflammatory response. Of course, there's also the downside of the fact that the inflammatory response is, in and of itself, often harmful in more severely ill patients. We often die of our inflammatory response rather than the infection per se. So what to do? What to do? Got me. I think the key thing is to not get infected. There are all these little clinical pearls that help you decide what's going on with a patient. One is timed positivity of blood cultures. As I've talked about in the past, if your blood cultures are positive in less than 24 hours for Staph aureus, that's associated with an endovascular infection. So it's an important piece of information. With Canada, that's more like 36 hours. How's about E. coli? Well, time to positivity was looked at 353 episodes of E. coli bacteremia and found that, the sooner you pop positive, the worse off you did. But in this case, it was less than 7 hours. And if your time to positivity for E. coli was less than 7 hours, you had a higher incidence of a active malignancy. Well, you should have figured that out beforehand. Neutropenia, same thing. But it was more likely to be a primary bacteremia, and patients who had rapid time to positivity had much poorer outcomes, with a hospital mortality of 43% if your blood cultures pop positive in less than 7 hours. So early positivity of blood cultures is a marker that the patient is going to do badly, as well as a marker that is a primary bacteremia, probably associated with neutropenias and malignancies given this population. It's always fun pronouncing an antibiotic that you've never heard of before. So, Fidaxomycin, fidaxomycin. That's how I'm going to say it for this podcast. Fidaxomycin is a, quote, macrocyclic antibiotic is more active in vitro than vancomycin by a factor of approximately 8 against clinical isolates of C. difficile. So saith the New England Journal of Medicine. Now you'll remember that I talked about a vancomycin stool pharmacokinetic study last podcast where levels of vancomycin in the stool are several thousand times that the MIC of vancomycin. So that probably is unimportant. But we do need other agents to treat C. difficile. Perhaps fidaxomycin might be the one. So this study was in the New England Journal of Medicine, and patients were randomized to get either vancomycin or fidaxomycin. Fidaxomycin. I'm not even going to edit that out. For the treatment of their C. difficile in a modified intention to treat analysis. They found that fidaxomycin was non-inferior. There was an 88% success rate with the fidaxomycin and an 85% success rate, round up, make that 86%, to vancomycin. So they're pretty much the same. However, in the fidaxomycin group, there was less recurrence of disease. 15% recurred in the fidaxomycin group versus 25% in the vancomycin group, which is consistent with most historical controls. You can predict about 1 in 4 to 1 in 5 patients will relapse their C. difficile, and that was statistically significant at 0.005. They were similar in their adverse effect profiles. I do not know, as I do this podcast at home on a Sunday morning, whether or not it is available for use, but it appears that we can add fidaxomicin to nitazoxanide and tigecycline as alternative agents for the treatment of refractory or other C. difficile. It will probably cost an arm and a leg, but is well worth it, right? Cost is no object in American healthcare these days. And by the way, there may be a reason for its superiority in relapse. One, fidaxomicin kills C. difficile, whereas vancomycin is only bacteriostatic. It's also narrow spectrum, which means it's going to impact the bowel flora less. And also it has a prolonged post-antibiotic effect not seen with vancomycin. So if you inhibit it, kill it, and don't affect the normal flora, that would make sense that you'd have less relapses if you used this agent. Of course, it also makes sense that the world is flat and that the sun goes around the earth. Using antibiotics to prevent infections is always probably futile. There's a whole rant I do about the fact you don't need to double cover Pseudomonas. The double coverage probably, if anything, accelerates resistance. But being on pseudomonal antibiotics does not prevent you from acquiring Pseudomonas. This study looked at a bunch of patients in an ICU to see who acquired Pseudomonas and why. And one was being near someone who had Pseudomonas. Another was having indwelling devices. But interestingly, and here I shall quote, all patients who acquired Pseudomonas aeruginosa, except one, had received antibiotics before acquisition. Among the 106 patients treated with antibiotics, 2/3 received at least 1 day of antibiotics active against Pseudomonas aeruginosa, whereas 1/3 did not, end quote. So having patients on an anti-pseudomonal antibiotic doesn't prevent them from developing Pseudomonas. In fact, the majority were on anti-pseudomonal antibiotics. And that's really a bummer, isn't it? I mean, you'd really like it that if you were on an anti-pseudomonal antibiotic, the patients would not acquire that organism. Doesn't work. One would think after all these years we would have identified all the mosquito vectors of malaria. This is not the case, according to science. What they have done over the years, because in Africa, has been to collect mosquitoes from inside of houses, because mosquitoes inside the house are very easy to catch. And of course, all the pesticides have been used in houses to help get rid of mosquitoes, the vector of malaria. What they did was collected mosquitoes from the outside, and they found a whole new mosquito that no one had ever found before. You'd think after 2,000 years of swatting these buggers that we would know all mosquitoes now. What they found about this mosquito is it's different than the classic in-house mosquito. It's very susceptible to malaria. It has a preference for human blood. It's abundant in Africa. And it likes to rest outside, not indoors. So that may be, and they're working out exactly to what extent, a prime vector for the spread of malaria in Africa. But just go think about it. They've discovered a whole new mosquito in Africa. There's always something new under the sun to suck your blood. And now, your favorite part of the podcast, and mine, the hodgepodge. Quickies without any long-term explanation. The CDC reported a case of human cowpox in a lab worker who evidently picked it up from the environment. The lab worker had also evidently declined vaccination for cowpox, even though they worked in a cowpox laboratory. Smart one there. I talked a while back about a study that showed that patients excreted West Nile in their urine for a long time after they had West Nile. This study was repeated and found 40 people who had had a history of West Nile, and 0, nil, none, nada of them had West Nile in their urine. So whether or not that's true or not, or maybe it was a lab error, has yet to be elucidated. They have evidence that HPV can affect the placenta, although the clinical implication of these results remains to be elucidated. Speaking of HPV, the HPV is found effective in preventing HPV infection in males. This was published in the New England Journal of Medicine and tested in 4,000 healthy boys between the ages of 16 and 26. Remember, not only does HPV cause cervical cancer, it's associated with rectal cancer, penile cancer, and oropharyngeal cancer. And males may indeed be the vector by which it gets to females. So it's probably a good idea, if you like to do public health sorts of things, to get your young boys vaccinated against HPV. What's the best statin for HIV patients? I don't care. But according to this comparative effectiveness and toxicity study in clinical infectious disease, atorvastatin and rosuvastatin, rosuvastatin, are preferable to prevastatin in HIV patients due to better effects and less toxicities. I will now promptly forget this, because if my patients need statins, they need another doctor. Again, a review. What are the big risk factors for dying from influenza, H1N1 influenza, pregnancy, and being obese? And they found that half of Californians greater than 20 years of age hospitalized with H1N1 were obese. I assume half of Californians are obese, but still, it increases the odds of death. And being obese and getting influenza is a bad combination, and they should be a group to get early therapy as well as be selected for vaccination if there's a shortage. Speaking of vaccinations, 2 doses of the chickenpox vaccine are better than 1 in children. I talked about before, herpes zoster is increasing in incidence, and this has been confirmed in clinical infectious diseases, where they found that shingles has been increasing across all age groups. They concluded that it was not due to the vaccine, although I'm unenthused about that particular conclusion from the study. The reason people get zoster, one would presume, is declining immunity, and by giving the zoster vaccine, you give a boost to their immunity so they don't get zoster. If there's vaccination in the community, then people are getting a waning in their immunity because they're not being exposed to children with chickenpox. And so, although they did not find that the use of the vaccine was associated with the increased incidence of zoster, I don't buy it on basic principles. If you get a tick bite in the Netherlands, your chance of getting an infection such as Borrelia are less than 1%. Now, I want to emphasize here, the Netherlands refers to a country in Europe and not the area between your belt and your knees. Syphilis is changing in its variation in England, and they're seeing more primary disease, particularly in men who have sex with men, which is the same as you see in the United States. That is a growing population to get syphilis, and keep that in mind when you're traveling to England this year for vacation, to wear your condom when you have sex with strangers. Of course, I'm talking to infectious disease doctors, and you're unlikely to forget your condoms, right? Now, it is interesting that leptospirosis is common in Hawaii, and when you're swimming in that beautiful, warm, freshwater pond, just remember that upstream is cow piss, and in the cow piss is leptospirosis. What's interesting is there's been a change in the epidemiology in leptospirosis in Hawaii over the last decade. It's gone from a summer disease to a winter disease. It's gone from a recreational disease, which is plateaued, to occupational exposures, and the type of leptospirosis has changed. It used to be icterohemorrhagia, and now it's Australis. So if you're not going to go to England to have sex with strangers, when you're off in Hawaii, remember when you're swimming in the lakes and streams that are ever so nice, you're swimming in cattle piss and leptospirosis. How often does Lyme cause death in the United States? Well, in this study, they looked at 114 death records from, isn't that a heavy metal band? Anyway, they looked at 114 death records and found only one record had clinical manifestations that were consistent with Lyme disease, although 114 put Lyme as a cause of death. So they would conclude that Lyme doesn't kill people. Use it and lose it. Mupirocin resistance is increasing. And in this study out of Houston, Texas, 14.7% of strains of MRSA were resistant to mupirocin. I should phrase that differently. 14% of staff were resistant to mupirocin. 21% of MSSA were mupirocin resistant. 8% of MRSA were mupirocin resistant. So interestingly, MSSA was more likely to be resistant to mupirocin, i.e. Bactroban, than MRSA, at least in Houston. Now, there's been a push in my institutions to look for MRSA nasal colonization and put people in isolation because of it. If they're in the ICU, that's mandated by the state of Washington. And also with the New England Journal article that suggests that if you decolonize or at least beat back the MRSA in surgical patients, you will decrease your overall MRSA infection rate. This study looked at other sites of MRSA and found that the nose accounted for only 55% of colonization, and that many patients had extra nasal MRSA colonization. So just remember in your ICU and stuff that the nose is just a marker of MRSA, but it's not definitive for MRSA colonization. Hypothermia is a cause of postoperative wound infections. So you like to keep people euthermic when they are coming out of the OR. On the other hand, hypothermia can be beneficial, for example, perhaps in traumatic brain injury. And this retrospective study found that patients who had prolonged hypothermia for severe brain injury did not have an increased infection risk over those who were not hypothermic. So while hypothermia may be a problem postoperatively for wound infections, it may not be as big a concern in patients who are hypothermic for other reasons. Do you know what a kinkajou is? I don't know what a kinkajou is. This guy in Indiana had a kinkajou. He was a zoologist, and somehow his kinkajou came down with blastomycosis. It bit him, and he got blastomycosis in his hand. The kinkajou subsequently died, and they found blastomycosis in its lungs. So, if your pet kinkajou is coughing, don't let it bite you on the hand. A kinkajou, by the way, is also known as the honey bear, and is a rainforest mammal of the family Procyclonidae related to ongulus, cotis, raccoons, and the ringtail and the cacomystle. Yeah, right, like I know what I'm saying. It's sometimes mistaken for ferrets and monkeys, but is not related. They are hunted for their pets, for their fur. They're used to make wallets and horse saddles, and people like to eat them. People have all sorts of weird-ass pets, by the way. I've heard that there's more money to be made in smuggling animals than smuggling drugs. So don't be surprised if your patient has some weird-ass animal and gets bit by it. This guy was a zoologist, and he had lots of strange animals as a consequence. But my theory is that people who have weird pets do so because they do not have a personality, and they substitute a weird pet for being actually interesting. And I say that to all my ferret owners out there. There was an outbreak of cocci in 3 patients who received organ transplants from a single donor who actually had cocci as well. So I just thought that was a curiosity. They looked for the reservoir of Penicillium marfanii, which is a fungus found in Southeast Asia, and they found 100% of the bamboo rats were infected with this mold. So it would appear that that is the source, at least in humans, for penicillium, although where the bamboo rat is getting the penicillium is not known. If your mother has tuberculosis while she's carrying you, she's more likely to spread HIV to you at the time of delivery. Not you personally, but you know what I mean. As they say, maternal TB is associated with increased mother-to-child transmission of HIV. Treatment of angiostrongyloides, the best may be albendazole, you know, my friend Al, and at 20 milligrams per kilogram, and 3 milligrams of dexamethasone, both daily for 7 days. Those who got a combination of albendazole and dexamethasone got better faster with fewer side effects. There's a case report of Plasmodium falciparum being spread by occupational blood exposure, and another case of blood transfusions in France. Just remember, wherever you have blood and people donating blood, you run the risk of malaria. In England and Scotland, they make people wear short-sleeve shirts at work to prevent the spread of nosocomial infections. Unfortunately, the study looked at the acquisition of bacteria in patients who had short-sleeved uniforms versus long-sleeved uniforms and basically found no difference. As soon as you put on clothes, you become awash in bacteria. My personal metaphor for human beings is Pigpen from Charlie Brown. We are all always in this haze of shedding skin cells and bacteria. And it makes sense that having short-sleeve shirts should make no difference in how rapidly you acquire bacteria from your environment. I think if we irradiated our employees, maybe we could get rid of the bacterial carriage rate that way. Should you wear sterile gloves when obtaining blood cultures? The answer from this study is routine sterile gloving before venipuncture may reduce blood culture contamination. So it's something to consider if you're having a high background rate of blood culture contamination in your lab, which is an expensive thing to have happen. We're at 31 minutes and 52 seconds. I think it's time to stop, don't you? Yes, we're at the end of another Persiflager's Puscast. Sad, isn't it? This one covered the first 2 weeks of February 2011 and reviewed the infectious disease literature with occasional asides. There are references available on the website, except for those that are in the hodgepodge, but you can Google, can't you? If you can't Google, what the hell are you doing in healthcare? Now, this is CME accredited. You can take the online quiz and get a free half an hour of CME. Thank you, as always, to Legacy Health. This is brought to you by Pusware, LLC, the publisher of the Infectious Disease Compendium, a Persiflager's Guide. This is available online. It's an iPhone, iPad, iTouch app, and it's a Kindle book, which means if you have a Kindle reader, which is available on every computer platform, you can have the guide. You can have a BlackBerry, you can have a Windows phone, you can have an Android. All you have to do is download the Kindle app and you can read and use the Infectious Disease Compendium. Isn't that special? And if you go to my website, you can get both the compendium and the Pus Whisperer, my collection of my first year's worth of blog entries, both as ebooks for a mere $5. And don't forget the rest of my growing multimedia empire, which you can find at moremark.squarespace.com. As always, there's nothing that makes my little heart go pitter-patter than good reviews. So if you've read my books, if you use my apps, if you like my blogs, if you listen to my podcasts, please write me a good review. Or in lieu of that, write me a check for $10,000. Either one to make me very happy. And as always, this is copyright 2011 under the Creative Commons license. The music is by my son when he was improvising on the guitar at the tender age of 12. He starts college this fall. They grow so fast. And finally, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and interesting case. I shall continue to follow along with you. Thank you. In dictation, goodbye.